This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. A few notes about today's episode. First, I am so excited to share with you that the domain for the podcast is finally live, and you can now find all the episodes and more at mydpcstory.com. Second, I wanted to ask a favor. The words of each and every one of these DPC and direct care doctors are here for all to learn and get inspired by. This week, I ask that you tell one person about the podcast to help perpetuate the direct care movement. And if you like what you're hearing, please leave a review on Apple Podcasts. This can help get the word out as well. Now, onto the episode. There is some explicit language in today's interview, so please be aware of this in case there are young listeners nearby. Thanks for tuning in today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
Direct primary care is the mechanism through which we can practice medicine the way we all envisioned it should be practiced. I'm Dr. Mitch Lee of Thrive Direct Care, and this is my DPC story.
Dr. Lee is a board-certified emergency medicine physician. He attended undergrad at Northeastern University in Boston, where he obtained his BS in health sciences. He then received his MD from the University of Massachusetts Medical School, and then went on to an internal medicine internship at the University of Maryland Medical Center, Baltimore, before completing his emergency medicine residency at St. John's Hospital and Medical Center in Detroit. He is currently on the board of directors for the American Academy of Emergency Medicine Physicians Group. He opened his DPC doors in June of 2020. Welcome to the podcast, Dr. Lee.
Thank you very much for having me here. I love your enthusiasm about all this.
It's definitely hard to not be enthusiastic about this movement, for sure, especially now that we have a new voice on the podcast. I'm really excited to talk with you and hear your story, especially given that you are, from your background, an emergency medicine trained physician.
Yeah, the emergency medicine component is a bit of a story in and of itself. I started back in Massachusetts, where I worked as an emergency medical technician. And there were a few inspiring moments during that time, but I was also studying health policy and really interested in primary care at the time. So it's been a bit of an overlap for me.
With you being exposed to primary care in the form of health policy, looking back on when you learned about health policy through your emergency medicine training and now your transition to DPC, can you give us a little bit more detail as to how you came across the idea of the DPC practice or the DPC movement?
Yeah, that's a long story, but I think when I look back I had this conception of what a physician would be, and I think I'm about 100 years too late for it, which is a physician that really could be a community physician, but also take care of when things got really rough, when shit hits the fan, basically. And that's how I really envisioned being a physician. Something, an emergency happens and I can take care of it, but also there's some continuity. And in medical school, and just before that, you started to realize you can't be that physician anymore in modern society. And that was kind of a disappointment, really, until I discovered the concept of direct primary care, at least from the angle that I'm coming from. So this I only discovered really about a year and a half after residency, and it was a bit of a eureka moment.
With regards to your journey, one of the things that I have seen you talk about is Fitfire. Can you share a little bit with the audience as to what that is?
Sure. Yeah, I'd have to back up a little bit just to kind of give some context. But the way that I discovered DPC is a little non-traditional, but Josh Umber, who's very well known in the DPC world, did a podcast on Dr. Money Matters. And I discovered it through that. That is how I heard of the concept of DPC. The context there is that I went to medical school at UMass Medical School, went to residency ultimately in Detroit, became an emergency physician, and I was about $300,000 in debt. So I started my first job as an associate EMS medical director with that EMS background and some tactical medicine background, actually, in Wisconsin. And that was sort of my way of doing a EMS fellowship, but also making an attending salary and starting to chip away at my loans. So I met another physician, Chris Tanner, who I almost started the DPC with. And he is one of the first people who actually showed me the concept of DPC by pointing out that episode on Dr. Money Matters. We spent about a year and a half, honestly, it was like a book club, but we would discuss personal finance matters, White Coat Investor, Physician on Fire, and a few other podcasts and books, and just learned, how do we not screw this up? How do we pay off loans and reach some sort of financial stability now that we have a good paycheck? And during that, I actually listened to that first episode, I think it was episode 6, with Josh Umber about direct primary care. I listened to 5 minutes of it, and I was like, screw this shit. This doesn't have anything to do with my personal finance. So I skipped it. And my friend, Chris Tanner, the other emergency physician, was like, hey, have you listened to that episode? And I was like, nah, that looks stupid. And I went past it. And so I re-listened to it after he mentioned it. And then I listened to it again. And I'm like, holy shit, there is something going on here. This is kind of mind-blowing, honestly. And I should say that I've also polled other emergency physicians and asked them things like, how much do you think it would cost to get your annual labs done out of pocket? And nobody answered what we know it to be in DPC. Not $3-4 a lab or under $30 for your annual labs. Everybody was writing $300 or thousands of dollars, or gave their stories about how they personally got hit with a $400 copay for their own labs. And it just kind of showed me how in the dark we are as physicians, how exploited we are as physicians, both in terms of working in medicine and also as patients. We might be fortunate enough that it doesn't bankrupt us all the time, but we are in the dark. And so this was a eureka moment for me, and that's how I discovered DPC. And I dove down the rabbit hole after that.
You mentioned that along this journey to learn about DPC, that both you and Chris Tanner had talked. Had you ever entertained the idea of opening a DPC with another doctor?
Sure. Yeah. So as you pointed out, I'm emergency medicine trained, which I'm sure a couple people understandably would raise an eyebrow. Well, that's it's not family medicine. It's not internal medicine. It's not really a primary care tract. I thought into that, myself, and I could answer that in a number of different ways. But one of the things that bothered me when I was first opening a DPC, because in the standard protocol, you're supposed to be available 24/7. And if I were still to be working in the emergency department, then I felt like, I can't open a DPC because I'm not available all the time. And at the time, my friend Chris, who pointed this out, we started planning to open something like this. And that way we could have 24/7 coverage, between the two of us. And we actually entertained one other physician in this as well. And that moved forward pretty well, but actually, I don't think he would mind me explaining this, but his father actually died, kind of fairly unexpectedly. And he actually more or less inherited a small ambulance company. And so all of a sudden he had a whole lot on his plate. And a few things fell through at once to the point where he wasn't going to be able to move forward. And I didn't feel like I could move forward by myself at that time. So actually it really delayed the opening of this about a year.
During that year, did you continue planning in terms of the business plan for your DPC or the physical location for the DPC?
So honestly, that year I kind of hunkered down and I started working emergency medicine shifts as an independent contractor. I don't know if I mentioned, but I left my job as an associate EMS medical director, which involved a ton of call time. And I felt like my life was just completely controlled by the hospital I worked for, which I think a lot of DPC physicians can empathize with. So I started working as an independent contractor, which is another rabbit hole that I've gone down, and am working in that world as well. But during that time, I just needed to pay off some loans and get myself an emergency fund, and gain some financial stability, which is, again, how I sort of found DPC. And that's also what allowed me and has allowed me in the past 4 or 5 months to really dive in. Honestly, I didn't really think too much about planning it in the last year until maybe March and April when the pandemic hit. And that was the trigger for me to say, you know what, some of the barriers to entering DPC, it allowed me to think outside the box. Some of the biggest barriers to starting DPC was the financial cost. And since I have been paying off my loans, I'm just a bit debt averse. So I wasn't really excited to take out a big loan for a business. And of course, this depends on your goals. You might need to take that big loan out if you want to get a practice moving really quickly. But I found in March and April that, nobody wanted to go to the ER. Nobody wanted to go to an office because they all thought they were going to get COVID. And so telemedicine was becoming much more practical and accepted. So I figured I could start a DPC that it was mostly telemedicine. And that's how I started. And now I have a little bit of an office, but it started in a hybrid model. And I just kind of dove in, as people say.
How was your experience opening as that hybrid with the telemedicine focus in the beginning? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
So it actually went quite well because I would do telemedicine and also had the ability to do home visits. Having been an EMS medical director, but also working in the field, I am very, very used to bringing in, equipment into people's houses or in the field. So it just felt natural to me. That being said, after a little while, I just felt the need to be able to tell patients that I had some neutral space to meet them. And that snowballed with Dr. Claude Ryan as a mentor into, hey, you should look into an acupuncturist's office or something. And I spoke with a couple of friends, one who was an acupuncture student, and they referred me to Mitch, who's an acupuncturist, but also very responsible, I should say, not quacky and not too out there, very responsible. And I contacted him, and it worked out that I got a space for $200 a month. It's a room that I use once a week, but he's also very accommodating, so I can it's very flexible. And so I've kept my overhead extremely low. Really, it's just my office space for $200 a month, Atlas for $300 a month, and then my malpractice insurance at $5,500 a year, and then some equipment. So honestly, it's been excellent to do that. I'm so glad I did that instead of getting a lease for $5,000 a month to start with.
This is all really important information to hear, because one of the number one reasons we hear that doctors are hesitant to move into the DPC world is because of being debt averse, just like how you described. With regards to your space, how does that work into your clinic now? Do you have patients every day, or how does that work for you?
Yeah, I mean, that's a good question. My background as an emergency physician, I've worked it out in my independent contracting schedule, which is out of state. I work in Wisconsin. I live in Chicago. I would not practice emergency medicine in Chicago unless something very weird happened, because the liability environment here is terrible. But it works out that I can drive up to Wisconsin, and there's no non-compete issues because nobody really cares what I'm doing in Chicago. So I tend to do that on Sunday, Monday, Tuesday, most of the time, like 3 times a week or 3 times a month, which allows me some regularity in my schedule. So I have a Thursday clinic where I have the ability to see patients in person. And so I try to arrange my schedule so that my in-person visits are on Thursdays. And otherwise, I'm fairly flexible for doing appointments on Wednesdays or Fridays. And of course, my patients still have access to my email and can always text me anytime. I just may not necessarily be able to do an in-person visit the next day like some DPC doctors can. And that may change as I expand. I might have some arrangements with another physician to do coverage on a regular basis, for example.
You mentioned that one of your mentors is Dr. Clodagh Ryan, and I know that in the past you've also worked with Dr. Amber Price, who's doing DPC in pediatrics. Tell us a little bit about how those relationships work, because you guys are geographically close to each other.
Yeah, that's worked out great. So honestly, the way I was introduced to DPC was through Josh Umber. So I kind of got the concept of DPC through him, and that's what was really inspiring. I had a couple of good conversations. As a lot of people know, he'll do some consulting that's not charged for, and generally is very enthusiastic about the field. So I spoke with Josh a couple of times, and then after that, I started looking around in my area. I should also, small digression, mention that while I was learning and diving down the rabbit hole of DPC, I was watching a video from one of the conferences of Jeff Gold. And while I was watching that, I was like, you know what? My dad probably should get a DPC doctor. So I checked on the DPC mapper, and I found the practice that was closest to him. And I was like, that guy kind of looks like Seth Rogen too. And it was Jeff Gold. So I was watching the video. I had freeze framed up on my computer when I was doing that. And Jeff Gold's actually my family's family physician now. So that worked out pretty serendipitously. And after that, I started looking in my area with like what DPCs are around here. And I just kind of clicked around and said, you know what, like Dr. Ryan's DPC really looks like the model that I appreciate, the inspiring kind that really, stuck to the values that drew me to DPC in the first place. So I contacted her, and basically, I visited her practice once, and we've been in touch frequently since then, and bounce ideas off of one another. And so it's very inspiring, and it's very helpful to have somebody like that nearby. So I'm excited to move forward with that. Amber Price, as a pediatrician, makes a lot of sense for collaboration with me, because I, as an emergency physician, it's just partly my comfort, right? I don't want to jump into things that that I don't know anything about, and knowing your limits is probably a skill of a physician that I think is important. And while I'm comfortable with the acute pediatric patients, and I can tell you when your child is dying and when they're not generally, I am very bad at growth charts and general developmental milestones. That's not my thing. So it makes sense for me to work with Dr. Price, and that has been a great relationship because she's been able to send me some acute patients from the pediatric side, and many of her parents are looking for a DPC-like experience, but she can't give that to them as a pediatrician and vice versa. So I sent her some pediatrics. And so we're kind of like a complete package, but still independent practices.
You just speak to the heart of the movement. We're all here to help each other out. And that is fantastic that you guys are doing that, especially with relation to different demographics. So that is wonderful. And yeah, I love that. I love that Dr. Gold is your family's physician. That mapper is so helpful.
I know. I think it's inspiring. It's great to have, feel like I can have something trusted right now. And that's a real relationship that I have with both patients and with the DPC doctors. And that's super valuable going into our very, very, very uncertain world right now, noting that today is the day that Donald Trump got diagnosed with COVID in 2020. Just going to put that timestamp on here. We have a very uncertain world, so it's really nice to have a network of physicians and people that really care.
Absolutely. And, online or individual groups, it's something that happens all the time where, hey, my patient is going to be traveling down to San Diego. Could you talk to me about, if they can see you for a one-time visit if they needed to in an emergency or something like that? And in that way, this grassroots movement is really becoming apparent in terms of how powerful it is for anybody and everybody who has a DPC doctor or a DPC connection.
Yeah, absolutely. I mean, it's inspiring. And that would probably be how I describe DPC, honestly, is that it's just reinvigorating everything, all of the reasons that I and many of us wanted to get into medicine. Those things were kind of going by the wayside, I think, in the corporate employed system.
I cannot agree with you more, because it's embarrassing when you go into this calling, you go into this profession to take care of other people, and the system doesn't back you up at all. The system doesn't back patients up at all. And so when I have people who have the Medi-Cal or Medicaid equivalent insurance, I can't get them a rheumatology appointment unless they wait 6 months and drive 3 hours to see somebody. I mean, it's insane. And so when we have resources where people are getting accessible care to the point of, like you said, people can email you or text you, which is what a lot of DPC doctors have. It should not be revolutionary, but it is. And so, more power to the movement for providing that to patients. Your pricing is separated into essentials, concierge, and acute visits. Can you share a little bit about what those distinctions mean and how you develop those offerings?
So the different tiers that I have are based on probably the most common arrangement for DPC practices, which is age-based. And I'm not sure exactly who pioneered that. I learned it from Josh Umber. I'm sure he's one of the ones who started it earlier. And that has mostly made sense for me. But I also have worked with some more concierge type physicians. And when looking to get referrals, I think it's a kind of a fundamental dilemma that most DPCs face, which is the psychology of pricing your services too low. Two things. One is about, self-worth and what you value your own services and time at. The other part is the psychology of putting a cheap bottle of wine on the menu. And this is very well described in the restaurant industry and many other facets, where if you price something too low, then you're considered low quality, right? You assume it's low quality. So we want to provide affordable care to people, but if we price ourselves too low, then they assume that you must not be that good. So it's a little bit of a dilemma. And what I've decided is that I would have the basic age-based tiers, which are really in line with most of direct primary care. My prices might be a little bit higher than some other places, but also I'm in Chicago and my medical malpractice is ridiculous. And the rent and cost of living for myself is higher. So I think they're adjusted for geography and cost of living pretty much in line with DPC. But I thought I needed to have, I can't turn away, I can't have patients be, turned off by the idea that I might be cheap. And so having a concierge model is what's addressed that. And then I've tried to carve out what services might be truly concierge, meaning what is not required to live a very, very healthy life, but really is about convenience or vanity, I suppose. And so as I may integrate PRP into my practice is something that I'm exploring right now. Platelet-rich plasma. It's something that, having started actually as a phlebotomist first, and then being very procedurally inclined, just makes a lot of sense for me. But most of the indications for that, if they're aesthetic, I don't find to necessarily be fundamental to what people would expect of primary care. And so those are services that I might mark up, which is not typical of DPC, right? Most of our procedures will do at cost with medications or supplies marked up by 10%. So that, honestly, your typical skin tag taken off or a laceration repair is going to cost about $15. With things that are very time intensive, that might be for enhancing the everyday life. And this is a very complex philosophical discussion. Where do we draw the line between healthcare that's truly needed and healthcare that's truly elective? That's sort of how I'm integrating this. So patients can get access to, if, for example, I were to include Botox, but not for migraines, perhaps, but Botox for age purposes and aesthetics. Those things would be discounted in the concierge membership, and also additional home visits. I include 2 home visits per year, medically necessary to all of my patients. But if you are looking for a service where every visit is a home visit, then that would be under my concierge membership, where there's a discount for my home visits. Hopefully that kind of explains it. I know that was a little bit roundabout.
Well, yeah, I think it's a great introduction to just a different model of how you run your DPC, because it goes back to, if you've seen one DPC, you've seen one DPC. And definitely, we'll put your contact information at the bottom. Your website's going to be linked to your podcast blog. But yeah, I think that that's a great introduction as to, your thought process and the differences between the different levels of membership. So thank you for that. Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
Yeah, no problem. I think, honestly, if I don't have any patients currently enrolled in my concierge membership. That's not the focus of my DPC. I just want it there so people realize the value that they are getting at the Essentials membership, which is way beyond what you would generally get in a systems membership. So it's there partly as the expensive bottle of wine, and then if people really do value it, then it's available, and I will give them discounts on things like PRP or Botox if I incorporate those.
Absolutely, and I think that you've brought up a great point that as physicians, we really don't collectively know our value, whether we be in a rural location or a urban location. We have data it's hard to get sometimes, like MGMA data for value of RVUs, but when it comes to setting a price point, you're so right in that geographically it's going to be different everywhere, but also at the center of all of this price point talk, you have to evaluate how much are you worth. And I think that it's really been through reading, personally, through reading and talking to others um, that I've started thinking about, how much is a doctor, a family physician, an ER physician, how much are we worth? And so I think it's important to hear the comparison to that cheap bottle of wine on the menu versus the expensive bottle of wine on the menu, because it's really relatable. I mean, when you talk about that, we all know that what that looks like on a menu. Well, we did know what that looked like on a menu when we could go to restaurants easier, but that's so relatable.
Yeah, I think it's a real dilemma that we all face, but honestly, I think it's great that we do face that. There's, I don't want to get too dog down into politics and philosophy, but obviously there's a huge philosophical discussion about healthcare as a human right versus is it not. And I don't think it's a really productive discussion to have because what healthcare are we talking about, right? There's definitely scenarios when we have a lot of empathy and our heart aches when somebody can't get care. And then there's somebody who comes to the emergency department every week and then, punches the ER staff and says it's my right to be here. And you're like, oh, okay, this isn't, clearly there's a difference. It's not all healthcare is created equal. And you being seen by the ER doctor or any part of healthcare is not, it's not that simple. So I think we all face this dilemma, and I think it's a great thing that we do because we all do have some, almost everybody does, and the field should protect against people who have no ethics. But I think we went into medicine for a reason. And so our own empathy starts to play a real role in our business. And so when we actually do see patients that maybe can't afford our care, but clearly value us and want our care, then we have the ability to discount it or give, months free. But I think it's a healthier relationship. That being said, I think there needs to be a safety net in general in society, which is kind of society in general being a kind of a mess right now. But it's a healthy thing for us to feel a little bit of a conflict inside, within regarding how we should price our services. And that balance will probably result in something that ends up being ethical.
Yeah. And no matter what your opinions are philosophically or ethically, you've definitely hit it on the head with regards to you get to decide as the owner of your DPC what you are going to do about it. There's so many different ways that people have addressed the inequalities in medicine. And even when a person goes through a hardship as an existing DPC member, people losing their homes and jobs due to, the fires in California or due to the jobs not being available anymore due to COVID, whatever the situations are. I've seen doctors who have 10% of their practice as a DPC doctor. They don't charge for that 10%. I've seen others who have members contribute to a quote unquote Robin Hood fund. So it helps pay for those members who can't afford it or who are currently going through a hardship. I've seen other DPC doctors trade, services for membership. Like Dr. Neil Douglas had a member who poured concrete for him. So he has a concrete patio and he exchanged that for months of service. So there's many ways to go with the ebb and flow of medicine and people's financial statuses. But at the end of the day, you as a DPC owner get to determine what that response is.
Yeah, we have some autonomy, which I think is something that I think probably most most DPC doctors end up valuing quite a bit, is that autonomy. And I don't have all the answers, but I think it's just really healthy.
Yeah, and even just it's healthy even to the point of, like you said, just having it out there on the table. It's not a the elephant in the room that no one's talking about. It's something that, because we are looking at DPC as a business, as an entrepreneurship, as a return to the calling of medicine, it has to be talked about. I have become a huge fan of podcasts. Ever since Sarah Koenig hosted the first season of Serial, I was hooked. Now, creating this podcast has become part of my daily life. While it is an exciting new hobby, I also see it as a privilege that I get to interview so many DPC and direct care doctors. If you are interested in starting a podcast, let me tell you a little bit about Anchor. First of all, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more. You can make money from your podcast as well with no minimum listenership. It's basically everything you need to make a podcast all in one place. Download the free Anchor app or go to anchor.fm to get started. In terms of the value that you give to your patients, one of the things that you offer are posts on your blog entitled The Simple Path to Health. I want to ask about how you come up with content and how you use that blog to communicate with your patients.
Sure. So, I mean, most of the blog, I don't do like a daily update on that. I don't have the time or energy for like a very frequent update, but I can get back to why I titled it The Simple Path to Health and where that came from. And honestly, I look at medicine, I look at the healthcare system as a whole, and I think it's extremely complicated. And most complicated things are complicated so that they can exploit populations. And this is true for personal finance, and it's true for medicine and insurance products that are overly complex, so somebody can barely understand what their benefits mean. So the Simple Path to Health blog title was inspired by The Simple Path to Wealth, which is by J.L. Collins. And that's a book that really describes my personal finance philosophy. And, a lot of your listeners will probably think personal finance and automatically shut off and say, I don't want to deal with that, head in the sand. And that's kind of what a lot of financial advisors are counting on. And it's also what's holding a lot of us back, right? Family physicians who graduate with enormous amounts of debt, who are kind of relying on the public service loan forgiveness program or just pretending and hoping it goes away. It's an understandable reaction, but personal finance is really how I found this, and really the only way I could manage to start something independent as direct care, and even being an independent contractor in the emergency department. So The Simple Path to Health, I would recommend for everybody to read, every DPC doctor, every potential DPC doctor, and anybody, honestly, almost any patient or human. I think it's really straightforward. It's practical, and that's how I wanted to communicate health and wealth. And I actually, in the standard do no harm Hippocratic oath that we take, I include do no financial harm in that. I think financial harm absolutely equates to harm in terms of health, because we all know about how socioeconomic status affects health. And even mental health, right? This is truly holistic. I think that we really need to take that into account. So The Simple Path to Wealth and FitFire. The word FIRE is financial independence, retire early, which is a whole not quite different movement, but it really means that the definition is that once you can retire or can live off of 4% of your investments, you can consider yourself financially independent. And some people kind of maybe look at that as being greedy or just not noble. And honestly, I see it in the exact opposite manner, which is that you need to take care of yourself, not necessarily be living an extravagant lifestyle, but just be able to devote all of your energies to what you believe in. And so you don't have to be living in a mansion. You could live in a tiny home or a trailer. And if your lifestyle only requires $30,000 per year, then according to the rule of 25, which I would recommend looking up, you need 30,000 times 25 to retire. invested. So that's $750,000. And so it's actually pretty achievable for many people. So you can live an extremely frugal and humble life, but then once you can technically retire, you can then devote all of your energies towards whatever it is you believe in, whatever your values are. And so the simple path to health is sort of about let's, achieve health goals that will make you live a nice, healthier life. And also let's address things like direct primary care and health shares and insurance products that are compatible with you not becoming bankrupt and saving most of your money. So it's a combination of these things that inspire me that I hope I can share with patients and other DPC physicians.
On that note, recently you had hosted a Zoom meeting about financial health.
Yeah. So we're really juicy targets as physicians. We don't really think it, but in general, physicians are a big target for financial advisors and anyone who wants to make a small percentage of a large salary. I realize we're not orthopedists, but in general, we tend to have very little financial understanding and fluency. So we do tend to be pretty bad with our money. And this is what I dove into with my friend Chris Tanner in the first year out of residency. And what I realized is that all over the healthcare system, whether it's a financial advisor or whether it's an employer, which might be a hospital, it might be a for-profit hospital, it might be a nonprofit hospital, or it might be a big contract management group that is funded by private equity. Our lack of financial knowledge is really what allows us to be exploited and controlled. We really wouldn't stand for a lot of the BS that we're put through, the moral injury that we have in terms of what our handcuffs are in terms of patient care if we didn't have to. And so cutting our overhead personally, like, downsizing and really looking at what our values are, along with good financial management is, I think, extremely empowering. You can finally live according to your values. And that's how I define FIRE, which is financial independence, retire early. Some people, when they hear FIRE, just think, you're lazy, you're retiring, and you can go sip lemonade on a porch. I see FIRE as the way for you to personally live up to whatever your values are. So that's what inspired that talk. And I find that a lot of financial advisors tend to be poaching residents and physicians who are kind of naive and expecting that this person has my best interest at heart. And I just get really fired up about physicians and patients and people being exploited. That's one of my fundamental values.
And thank you for touching on that and also for creating that Zoom. If you have not heard or seen the Zoom meeting, there will be a link included in the blog post accompanying Dr. Lee's podcast. So please be sure to check that out. Do you have any tech or tools that you use and love?
I have a few different bags that I use. But what I'm finding to be very useful from a DPC perspective is remote monitoring. So I am working on incorporating Validic, which is I don't even know how to describe it. It's basically a software program that will, in cloud service, that will allow integration of a lot of medical devices, which it seems like they have a ton of partners into the electronic medical record system of Atlas. And so I love to monitor my patients remotely with blood pressures and scales being the main reason. That gives me a lot of data, and I've got a lot of patients who like data. And I'm able to do that without actually seeing them in the office. And, I think this is way more valuable than a patient who presents to the office once per year to have their blood pressure taken, which might or might not be quote unquote, white coat syndrome related. In the emergency department, I see patients referred to the emergency department all of the time because of an asymptomatic hypertension. And so I have to then either titrate the medications, which really should be the responsibility of the primary care doctor, or just discharge them. And I think having this more consistent monitoring to look at averages and trends is incredibly invaluable. So I love that. I've been looking at cardio So cardio arm with a Q. That's what Josh Umber had recommended. There's so many of these tools though to put together. So that's one thing. And then of course my Butterfly IQ, which we've talked about in the past, which is a very portable ultrasound that plugs into your phone or iPad, and is just like pretty awesome, I have to say. As an emergency physician, we've kind of adopted bedside ultrasound in the past decade, maybe, and it's so invaluable. I consider it as an adjunct to my physical exam in most cases. And the fact that Butterfly IQ has come out with a totally different technology that can emulate multiple different probes for like $2,000 makes it totally affordable for a DPC practice. So those are probably my favorite toys in this. I also use Cardio Mobile, a live core, which is a little 6 lead EKG thing, which for $150, I will not rely on that for like replacing a 12 lead EKG, but it's pretty slick. And if you're on a plane or something, an airplane, and somebody's sick, getting a 6 lead EKG to figure out their rhythm is pretty cool.
Coming from an ER doctor, that's really good to hear, because a lot of these products are still new to people, and some people listening might not have even heard of Cardia before. So that's really good to hear, especially from an ER doc, or ER trained doc, I should say. With regards to other physicians who might also be ER trained, or those who are finding out about DPC, whether it be through a financial podcast or other means, what would you tell those who are interested in DPC but are needing a little bit of extra encouragement?
I think it depends on their situation. Honestly, I think they need to get a hold of their personal finances first. And so I could sit here and just say, just do it, just jump off the cliff and have faith. And that's not how I think. I think you need to have a practical plan of some security. And my security is working as an emergency physician in the emergency department, which is, as an independent contractor, I could get dropped anytime. Theoretically, I don't have any employment protections, but I think you need that security somehow. So that security could be a runway, because you've saved up 6 months or a year of emergency funds. So if you cut your overhead, I think you have to make some value decisions. Cut your overhead for your home life, downsize if you need to. If this is that valuable for you, move to an extremely, like, the smallest house that you can tolerate. If you have a car, sell it. If you have a car that you're paying off, rather, basically cut your overhead as much as possible and have some form of income, or decide, save up for a emergency fund. And I think that personal finance, getting that house in order, is absolutely fundamental before you just take the plunge. I like to be realistic. And so it's totally doable. I think for anybody it's doable, but sometimes it takes some serious value and soul searching, because what can you sacrifice? What about spouse? If you have a spouse, what are their expectations? So there's a lot of discussion to be had there. And I would recommend looking into that first and getting that, go to whitecoatinvestor.com, go check that out. And then know that it's totally doable, that you can do DPC with very low overhead. So I have what would be considered a micro practice. So I am not making a lot of money, but it's also budget neutral. I'm not hemorrhaging money either. If you are hemorrhaging money, then you better be successful very quickly. And I don't like that kind of pressure. So it depends on your goals, but personal finance first, and then know that you can do this low overhead.
For those listeners who would like to reach out to you afterwards, what's the best
probably
way to
email.
get a hold of
They
you?
can email me at Mitchlee, MITCHLI, at thrive-directcare.com. I'm so glad you're doing this. We connected a couple of weeks ago, or maybe a couple of months ago now, and the world has changed a lot, but your energy is inspiring.
Thank you so much. Next week, look forward to hearing from Dr. Linnea Meyer of Wellscape Direct MD. Until then, this is Marielle Conception. For more information on this episode and much more, please visit mydpcstory.com.